a lot of speakers who are going to talk on this topic. And to introduce these speakers, I would hand over to our moderator, Dr. Rajkumar Amravati, who's a professor and professor and specialist with a particular interest in hip and knee arthroscopy as well as joint replacement surgery. And he operates at St. John's Hospital in Koramangala, Bangalore, India. Over to you, Dr. Rajkumar.
Thank you, Neeraj, for the kind words. And I'm sure we have all the speakers on board. I was told that Dr. Ashish will be joining us virtually. That's fine. And I can see Rajesh there and Dr. KJ Reddy sir and Charul on board now. I think Rajesh is going to give his first talk. Dr. Rajesh Daurani is going to talk to us on classification, Piquet and alert, Arco and Carbol angle for the next 10 minutes. Over to you, Dr. Rajesh, and we are happy to have you on this program.
Thank you, sir. Should I share my screen now? Is my screen visible?
Yes.
Okay. So, good evening, gentlemen. I will talk about the classification of osteonecrosis of femoral head. Osteonecrosis, as we know, is the osteonecrosis, as we know, is the death of femoral head as a result of vascular disruption to the femoral head, vascular supply, which comes mainly from the lateral epiphyseal vessels, which supply the lateral and central thirds of the femoral head, while the medial third is supplied by the artery of ligamentum teres. So etiology is diverse, including intravascular factors, extravascular factors. But these days, we see a lot of cases post-COVID, most probably because of the steroid intake or probably because of the hypercoagulable states that is associated with the COVID-19 disease. So coming to the classification should have good prognostic value. It should help us in uniform reporting of the stage of disease as well as selection of the best possible treatment. Also, in comparison between different, comparing the results of different treatment options. So most widely used classifications are Fickett and Earl classification, Arco staging system, and Carbol angle. So these classifications rely on investigations. So we'll look into a bit detail of these investigations. The radiographs, plain radiographs help in assessing femoral head shape changes, but they are not useful for early stages. MRI is the most sensitive investigation for early detection as well as accurate staging of the disease. CT scan is also very useful to assess the extent of involvement of the osteonecrosis. Bone scan, while it's very sensitive, but isn't used much for diagnosis and staging because of the more widely acceptance and more widely availability of MRIs. So the changes on the plain radiographs that we see throughout the disease from the early stages to the later are focal osteoporosis, osteosclerotic changes, cystic changes, crescent sign, loss of the weight-bearing dome, partial collapse, and finally the secondary osteoarthritic changes. The characteristic MRI finding of osteonecrosis is a focal lesion, focal geographic lesion, most probably in the anterosuperior portion of the femoral head, which appears on T1 weighted image as single band-like area of low signal intensity, and on T2 weighted image appears like a double line sign. That is a classical sign of AVN, which is made up of two concentric low and high signal bands. On CT scan, we have to look for subchondral lucencies, sclerotic areas, subchondral fractures, and collapse. Now, the most widely used classification is Fickett-Earl classification. It was the first one to be described for AVN and was originally consisted of 4 stages, which was later modified by Fickett to incorporate preclinical and pre-radiographic stage. Since then, it has been modified a few times to include MRI findings and to exclude invasive diagnostic procedures, which were earlier based on. So here's the classification, Fickett-Earl classification. In stage 0, everything is normal. Clinical symptoms worsen from stage 1 through stage 4, from mild, moderate to severe. Radiographs are normal in stage 1, and the lesion can only be diagnosed on bone scan or MRI. Radiographic changes start appearance from stage 2 onwards. In stage 2A, there is sclerosis, osteopenia, focal osteopenia, cystic changes may be there, but there is no crescent sign. While in stage 2B, there appears a crescent sign also. And stage 3 shows gross changes in the shape of femoral head with subchondral fractures, collapse, fragmentation, and necrosis of the femoral head. And final stage 4 shows full-blown osteoarthritic changes in the hip joint, along with narrowing of the joint space and vestibular changes as well. So this is a Fickett classification. It has its own limitations as it doesn't include any measurement of the lesion size or articular surface involvement. There is no prognostic importance has been ascertained to this classification. Also, there was use of invasive diagnostic procedures in the beginning. There is controversy regarding the inclusion of clinical symptoms in classification because they tend to vary from patient to patient. Also, there is inadequate inter-observer reliabilities. So the next one is ARCO. It was basically an adaptation of another staging system developed in the University of Pennsylvania, which was then modified a few times. So this is ARCO staging. Again, stage 0 is everything is normal. Stage 1, there's X-ray and CT scan are normal and lesion can only be seen on MRI or bone scan. In stage 2, X-ray changes start appearing, but there are no crescent sign. Stage 3, there is crescent sign present with or without flattening of the articular surface of the femoral head. And stage 4 is full-blown osteoarthritis. Now, stage 1 to 3 were further subclassified based on the location of lesion, whether it's medial, central, or lateral. They were also quantified according to the percentage of area involved, length of the crescent, and percentage of surface collapse, less than 2 mm, 2 to 4 mm, more than 4 mm. Now, this was ARCO classification, which was further simplified in 2019. And now, thankfully, the stage 0 was removed from this. Also, the subclassification according to location and size were removed. And stage 3 was subdivided into 2 stages, stage 3A and stage 3B. So now, stage 1, X-ray normal, MRI abnormal. Stage 2, where X-ray changes begin appearing, but there is no evidence of subchondral fracture. In stage 3, there is subchondral fracture visible with or without flattening of the femoral head. In stage 3A, there is femoral head depression less than 2 mm, and 3B, femoral head depression more than 2 mm. Stage 4 remains the same. And the last one is the Carbol angle, which was actually proposed to predict the collapse of femoral head. The idea was to quantify the extent of necrosis by measuring the arc of necrotic portion on AP and lateral X-rays. Of course, it was later modified to use MR images instead of X-rays. So now mid-coronal and mid-sagittal MR images were used to quantify the area involved, and they were, and that's how they reached the modified combined Carbol angle based on the MRI findings. So this is a study in which there were 37 hips were investigated over 5 years, and the end point was collapse of the femoral head. So the results of the study were, if the combined Carbol angle was less than 190 degrees, there was no collapse in any hip. If the angle was 190 to 40 degrees, 50% of the hips collapsed during the period of 5 years. And if the angle was more than 240 degrees, all of the hips collapsed eventually in 5 years. So this shows the great prognostic importance of the Carbol angle, which can be used to, identify the best treatment option and to compare results as well. Thank you.
Thank you, Doctor, for your wonderful talk. Now, questions can be taken now, Charul, or how we want the questions to be discussed in the end? What is the plan?
You can take question now, sir. You can take a questions now.
Okay. Anybody from the panel would want to ask Dr. Rajesh anything about his classification and the current concepts that has been given to us to classify AVN? Anyone? Okay. Dr. Rajesh, I understand we have been from time immemorial practicing to classify this AVN based on the Fickett and Arlett. Even now, we still do that. In your clinical practice, are you using the ARCO classification extensively, or you are switching from Fickett and Arlett to ARCO? Number one. Number two, how much importance do you give to the percentage of collapse of the head of the femur when you want to plan your management?
So recently we have seen that Fickett classification, because of the inter-observer variation, many MRI scans, we feel it is stage 2, but they have been reported as stage 3. This is very common these days. So Fickett classification is losing its decay over a period of time. So we gradually shift over to ARCO classification, which helps in better planning of the treatment options. And yes, what was your next question, sir?
How much importance do you give to the percentage of the head collapse that you see in the new classification?
Of course, the percentage that is collapsed, if the collapse is more than 2 or 3 millimeter, then you should think of something else rather than regrow.
No, I'm giving you a hypothetical question here. See, classification by Fickett and Arlett is stage 2. Okay. So when we ask the MRI guys to give us the percentage of collapse of the head of that particular side, where it is right or left, they say it is 50% of the head is collapsed. So now will that management change when you're thinking of doing something based on what the MRI has told you? Or you will still want to stick to your Fickett and Arlett and say it is stage 2 and I'll go with what I'm supposed to do?
Okay, so what you're asking, sir, is not the collapse. You are asking about the area of involvement, because in stage 2, there is no collapse. Correct. In stage 2 Fickett classification, there is no collapse of the femoral head. There is geographical lesion is present on the MRI. So if the area of involvement, geographic lesion in stage on the MRI is less than 50%, then we should plan to preserve the hip. That's what I do. So it's not collapse, it's the area of involvement basically. If there is collapse, it's already stage 3 or more.
Yes. So we are supposed to probably ask the interpretation to the radiologist to give us percentage of the involvement of the head. In addition to the stage that they give would be the message probably that should go across the panel here and to the viewers.
Yes, sir.
Do you agree, Dr. Reddy and others on the panel?
Yeah, I think Rajesh, that was a wonderful presentation about classification, because classification is always difficult, especially with the MRI. There is always debate between us and the radiologists.
Yes.
I just wanted to know, do you classify yourself? You read your MRI scans, you take what the radiologist reports?
So both are important. I mean, you can never be overconfident. You must see yourself. I see myself the MRI scans. I also sometimes, if I'm in doubt, I also ask them to repeat a CT scan also, to compare MRI and CT scan. And of course, you have to read their reports as well.
Absolutely. I think probably it is important that we discuss with them and we know what exactly we want. Because if they realize the treatment is different for different stages, we have to know, we have to ask them exactly if it's 50% or more or less. I think some of the what are the indications are clear to some extent. So it's better always to discuss with them, because sometimes for me, difficult to read MRI scans. So I go them, they show us, then we understand better.
Thank you, Dr. Rajesh. Thank you for your presentation. And now I call upon the second speaker of this evening, Dr. KJ Reddy sir, who is a senior orthopedic surgeon from Hyderabad, to give his talk on location of AVN region and how he selects his cases for OSGRO. Over to you, Dr. KJ Reddy sir.
Thank you very much, Rajkumar. That's nice to see you again.
Thank you.
And thank you for Regrow Company for organizing the excellent meeting, because day by day these cases are increasing. And one thing I think most of the audience knows, that the amount of necrosis is most of the time fixed. I think they should understand that at the time of insult to the head, it's very unlikely to progress, and in the sense in the volume of the head, the amount of the head do not progress over a period of time, but the changes will progress. So it is important to assess the amount of the head which is involved to decide the treatment options. So I'm going to talk some of the principle of mainly practical based. So when do you wait before you do any surgical intervention? What kind of cases? And when do you do surgical procedures? And when not to do some of the surgical procedures? These are the important things as you grow up in surgical career. These are the things you should learn. And as I think Rajesh has gone through in detail about the classification and about the diagnosis is important. Plain X-ray sometimes gives more information than MRI. So you should keep plain X-ray all the time. And that's useful for comparison as well, because post-operatively, you only see X-rays. Because if you do MRI scan immediate post-op or few months, within few months or years, there will be confusing because there will be activity and still it will be considered as AVN. Radiologist report as AVN only. So you have to be very important that you take X-rays and you must be able to read X-rays and keep good quality X-rays. And MRI is, as Rajesh said, is very sensitive and very specific because it is important to know the amount of the head is involved. If it is a significant amount, more than 50%, we won't be able to offer autologous osteoblast transplantation. So it is important to know what is the amount of head is involved. So the size of the necrotic lesion is important, and as well as its location of the lesion, especially in relation to the weight-bearing part. And most of the treatments are based on this, and their outcomes also based on the size of the location, as well as the size as well as location of the lesion. It can be medial lesion, or a central lesion, or a lateral lesion. And important to know that any lesion very close to the subchondral bone is very important because it's likely to collapse. If you do any procedure, then if you're too close to the subchondral bone, it will collapse and progress to further stage. So it's very, very important. You must be very cautious with these lesions which are very close to subchondral bone because they're likely to collapse. And lesions away from subchondral bone, they are good to treat with Osgro because they have better results. And we have observed, recently increased incidence. See, every day, probably I see 2-3 cases of AVN, mainly post-COVID, combination of COVID and steroids. And the lesions are quite significant. Previously, idiopathic one. We generally say idiopathic one will have a good prognosis because the lesions are not so big and progression may not be as bad as steroid-induced or alcohol-induced. But COVID-induced lesions or AVN, which is combination of COVID as well as steroids, probably have bad prognosis, and the lesions are quite big. And of course, this measure of Steinberg classification, which will say the involvement of the articular cartilage, that is important. I don't go into details, but this is one useful information from a Japanese recent classification. You can go through that also in relation to the weight-bearing portion, which is important when you are treating with Osgro. And of course, most of the time we follow corbel angle, which is a modified corbel angle, which is based on MRI. And as Rajesh rightly said, if it is initial stages, probably those in stage 1 probably may not progress So those people can be treated non-intervention. They can be observed. They can be treated without any surgical intervention. Maybe symptomatic, and especially they're asymptomatic, you don't have to do anything else, because the results are equally good. I mean, results are good after 5 years, as Rajesh said. If it is a less angle and asymptomatic, you can leave them well alone. So it is important for you to know when not to treat them. And of course, as I said, it is also important for the treatment purpose, quantification. Generally, we say if it is minimal, less than 15%, and asymptomatic again, we can leave them well alone. Probably they do well, because what we are worried is collapse. And what we're trying to do is prevention of the collapse of the head, so that the osteoarthritic changes will be prevented. So in less than 15% asymptomatic patients, you don't have to do any intervention. If moderate, between 15 to up to 50% of the head is involved, probably you can treat them with Osteo, and they have good results. If more than 50%, initial stages, I think when we did not understand about 4 or 5 years ago when we started with Osteo, probably I also treated with people beyond involving more than 50%, and the results are very bad. Yesterday only I saw one patient which was stage 2, other side was maybe stage 2B. Beyond that, it collapsed completely the other side, which was beyond stage 2B. More than 50% head is involved, whereas the stage 2, which was less than 50%, means a remarkable recovery. And one more thing for the youngsters, I think transient bone marrow syndrome, we should be aware. It can mimic, and you should know how to treat these conditions. So in general, subchondral bone plays very important role in management. And subchondral collapse, if it is more than 2 millimeters, you should not do Osteo, because they're going to collapse and it will progress further. Site is also important. If it is very close to subchondral bone, probably you have to think about other option. Or when you're treating with the Osteo, you should be very careful not to drill very close to the lesion. And we should be very careful treating weight-bearing portion of the osteonecrosis involving weight-bearing portion of the neck. This is one of the cases I just want to show, because X-rays are very, very important for later comparison. As you can see, is a young patient, bilateral AVN, MRI scan stage 2, and treated. This is pre-op X-ray. This is post-op. As you can see, this one is 17 December. This is immediate post-op in August 21. Not immediate post-op, probably after 1 year. And this is December 21. And this is in May, recently, a couple of days ago I saw. And this, I think, as you can see, the radiological changes. What I keep saying to the people, that most important thing is you should see any progress of the disease. You can see there is no progress. And probably here in the last X-ray, maybe there is some bone formation, but the congruency of the head is well preserved. There's a lot of debate when to do MRI scan. If you do within 2 years or 3 years, there will be still lesions, so you won't be able to compare the results, outcomes of treatment with Osteo. So I think the best way is to keep X-rays and see what would be the progression. And most of the time, the collapse or flattening of the head is the key that you're probably going to progress. If that's not there, I think you're quite safe. A lot of literature review. I think this recent one, Korean literature. So many treatment options they've described, but none of the options were very successful. So there is a good future for Osteo. because if I've done more than 200 cases now. Charul was saying the other day, probably we can publish and come out with the results. What are suitable cases and which are the ideal cases for to get good results. And I think, in my opinion, patients with less than 50%, with I mean, of course, symptomatic stage 2, without a significant involvement of the subchondral bone or minimal, maybe 1 to 2 millimeter subchondral collapse, would be ideal for osteo treatment. Thank you very much for listening. I think this I was saying about pre-collapse case is ideal. Subchondral bone should not be any collapse. Less than 2 millimeters. If it is, as I said, if it's a small angle, painful, if it is not painful, then probably you can leave them well alone. And weight bearing area, if there is a subchondral significant involvement, probably it may not be an ideal case. Thank you very much for your patience.
Thank you, Dr. KJ Reddy, sir. And now the paper is open for discussion. I see Dr. Palekar, sir, has joined us. Good evening, sir.
Hi, Dr. Palekar.
Sir, you are muted.
Yeah. Thank you so much, and sorry that I joined late because I'm leaving on vacation tomorrow. So a lot of last minute work pending. But yeah, thank you so much, sir. Thank you. Thank you, sir.
Sir, your thoughts on Dr. Reddy's presentation, sir?
It's excellent, actually, sir. I think Reddy, sir, covered almost everything. And my views are almost the same, and that the case that he showed, I have seen so many of these results where the choice of cases is very important. And like Dr. Reddy sir mentions, and now ARCO has also confirmed that we really do not require an MRI to see the progression of the lesion. What we require is an X-ray, where we look for the X-ray is the best investigation to see for subchondral collapse, and the progression should be seen as maintaining the sphericity of the femoral head. As long as the sphericity of the femoral head is retained, the patient will have an excellent result. And I usually use the Harris-Hip score for this. And Harris-Hip score in these patients is typically 90, 92, 95, which is actually equivalent to an extremely well-functioning total hip replacement. So I think that we are onto a great thing here, where we can definitely offer head-preserving options to younger people who are not really good candidate for a total hip replacement.
So just a thought that I wanted to discuss on this forum.
Yes, sir.
There was this young gentleman who presented like what Dr. Reddy sir was showing, kind of a transient change in the marrow of the femur, which was reported as linear stress fracture in the femur and query AVN.
Right.
And now, if you are looking at the head that was there, probably it would be grade 2, not moving on to grade 3 AVN. But they had put a query, though this gentleman is shopping all over the place, and then finally landed up with us. And finally, we had to take a second opinion, reconfirm the diagnosis, which was not AVN, but just a linear stress fracture.
Yes.
And then we had to manage him with only medication that was required, and is pain-free for that matter. But how often do we see that these kind of reporting, takes us to a wrong direction? Number one. Number two, the location of AVN that sir was mentioning is very critical. And I remember discussing in Goa forum where you showed where the AVN was only medial. And then you said we can go ahead and do only conservative way of management rather than doing anything active.
Correct, sir.
So your thoughts on that, sir?
If I'm not wrong, sir, I think I have also seen this patient. Like you said, the patient was shopping around, and I think he was a resident or someone, a doctor or someone like that. Is that the same patient, sir?
No, sir, he was little elderly.
Okay.
Maybe in his 45, 40, 40, 45 range. Yeah.
Yeah. So this guy, this doctor was also, I think he was an orthopedic surgeon, and I explained to him that this is definitely not AVN, and he showed me 2 or 3 MRIs, and poor guy was confused. He used to keep on getting MRIs done from multiple places, but eventually it was just rest was the solution. It was not AVN. One more thing I would like to point out, sir, that I some time back I received again a web consultation, and this young chap had developed hip pain. Now, this is one of the very rare instances where I have seen a hyperacute stage of AVN, where we don't, it has not been described also on, in literature, but this was a hyperacute stage where it was very difficult to make out that it was AVN because there were a lot of T2 signals. However, the classical band of AVN was absent. So what I asked him to do was I asked him to wait for a month and repeat the MRI, because it was definitely there, the MRI was not suggestive of AVN at the first time. And after a month, when he repeated the MRI, there were the classical signals of AVN. So it takes some time for, because of the availability of technology, there are chances that we may get more and more of these patients. But the classical definition of AVN, the double intensity sign that we see with convexity away from the joint, is one of the classical signs of AVN. And unless as we learn to differentiate that, we will be treating a lot of cases which do not require treatment.
Yeah, I think I agree with you, Gaurav. Recently, one of our neurosurgeon developed, and him, I mean, as you know, doctors were very bad patients. He went around and, so many opinions. If we see 10 doctors, there'll be 11 opinions. And finally settled with me. I told him I think it's not AVN, because I did not fit into those, you rightly said, radiological symptoms. And we already had 4 MRI scans. And if you carefully see, I think probably it was coming down. A good rest, good anti-inflammatory medication. I think it settled, but it took about 6 to 9 months. Sometimes it takes longer, and you have to, I think, very careful, because sometimes you can be mistaken and do something else. Probably most of these patients do well, but we don't see very often. Maybe once in a while, maybe once in 6 months, once in a year.
Dr. Rajesh, your thoughts on Dr. Reddy's presentation?
Unmute yourself, Rajesh.
Well, I recently had 2 doctors who had AVN. One was a medicine guy and the other was an ophthalmologist, but both of them had AVN, characteristic changes AVN, and we used Osgro, and they are having very good results. So one lady had a stress fracture as a linear stress fracture, but that was very rightly mentioned on the MRI. So I haven't had that an experience that MRI takes in the absolute wrong direction. That's it.
Okay. Thank you, Dr. Reddy. And
Thank you.
For all the panelists. And now I call upon Dr. Palekar sir to tell us when not to do Osgro. That is the key for all of us to know how to choose our patients and who are the right patients for Osgro. Over to you, Dr. Palekar sir.
Thank you, sir.
Thank you.
Thank you, Dr. Amravati. I'll just share my screen. Can you see my screen?
Not yet, sir. Yes, sir.
Yeah. So I feel that for a technology or a procedure which is very new, we need to understand when not to operate equally well as when we need to operate. So this is has been my experience about when not to operate on people with this kind of with Osgood cells. So first is whenever the diagnosis is in doubt, like Rajkumar sir mentioned right now, that sometimes the diagnosis itself can be in doubt. So we have various things like bone marrow edema syndrome or transient osteoporosis of the hip or a subchondral insufficiency fracture. When the disease severity is either too little or there is a too much of disease, and there are associated diseases which prevent a successful outcome of the disease. So these are the conditions where I feel that we are setting up the patient for either a wrong surgery or we are setting up the patient for failure. So things which mimic AVN are basically a bone marrow edema syndrome and also called as transient osteoporosis of the hip. And second is a subchondral insufficiency fracture of the femoral head. Now these are both relatively rare disease, but they can be mistaken for osteonecrosis. They have very distinctive clinical and radiological pictures, and which will help us differentiate them from osteonecrosis. Now, bone marrow edema syndrome or transient osteoporosis hip is classically a patient where the patient comes with a very severe limp and pain, and the symptoms are completely disproportionate to the clinical picture. So your X-ray will be absolutely normal. The patient will be severely limping or in severe pain. It is characterized by a absolutely normal range of motion of the hip. So there is very rarely even a synovitis to prevent a terminal restriction of hip range of motion. It is always unilateral. Somehow it is more common in middle-aged people around the 35 age group or so, or in females during pregnancy. Now, what we see in this region is, I will just take you to a picture. Now, as you can see on T2 images now, that the whole proximal femur right up to the trochanter is lit up like almost there is a Diwali going on there. And in second thing is that in the subchondral region here, there is a
I think Dr. Gauresh's network went off.
Yes, if you can help reconnect with Dr. Gauresh, it will be nice.
I call him.
Yeah, and I'll call him, sir.
Gaurish sir is muted.
Yeah, yeah, he's back. 1 minute, I'm texting. Yeah, he's back.
Yes, Gaurash, share your screen again.
yeah. I think I lost the connectivity.
Yeah.
Yeah.
So you are speaking about bone marrow edema.
Yes. So as you can, 1 second. So as you can see, there is the proximal end of the femur is completely lit up on T2, and there is a thin band of dark here as well as here. There is a thin band of dark. This is very characteristic of transient idiopathic osteoporosis. Now, like I was saying, I have suffered from it myself. For the first hip, when it involved me, I took a lot of care. But for the second hip, I did not do anything and I just recovered fine. So no calcium, no rest, no vitamin D, and still it becomes okay. It reminded me that I have become a middle-aged person. That's all that it did for me. Second thing that is very common is the subchondral insufficiency fracture of the femoral head, or SIF. This is typically seen in elderly people where you get a subchondral discontinuous radiolucent line which is parallel to the articular surface in both a T2 as well as T1 images. DEXA scan would reveal that very low T scores. And as you can see here, the AVN, the low intensity sign is convex away from the joint, while in SIF, it is concave towards the joint or it is parallel to the joint. This is typically known as SIF. So these are the two things. Again, SIF as disease, it can go either way. And here I want to show you a case of a 80-year-old female who developed hip pain, no history of any steroid trauma or anything. The pain subsided. She was investigated by a spine MRI, which did not reveal anything significant. DEXA revealed severe osteoporosis, and this is her MRI report after 6 months. As you can see that there is a subchondral line which is parallel and it is almost following the joint surface. The X-ray revealed this picture and reduction in the joint space. There is a change in contour of the femoral head, and this basically required at that stage, she was 80 years old, so I did a bipolar on her. Second thing is that if the severity of the disease is very high, so I feel that once the contour of the head is lost, the patient needs to undergo a hip replacement, as it is a very good salvage procedure for such a hip. If there is a more than 2 millimeter collapse, that is, if the patient is in ARCO 2B, again the fate of the joint is sealed. However, if the patient is in ARCO 2A, I have got a sufficiently large follow-up which shows that less than 2 millimeter collapse is compatible with a fairly good joint function, so that the patient is able to carry on for 8-10 years easily without him requiring a hip replacement. The advantage of this procedure being that the patient can do the normal functions that a person wants to do, like sit on the ground, do trekking, and most of the active things they are able to do. Other thing is that AVN associated with renal transplants is very common because of steroid. However, the patient is always going to be on cytotoxic drugs, and this is detrimental to the cells that we are injecting. I have tried it in one case, but it has not worked. In severe sickling disease, where unless the patient is ready for a bone marrow transplant, there are very high chances of the patient developing recurrent AVN because of the nature of the disease. Also, whenever there is a severe restriction of the range of motion of the hip, and when you watch the MRI and there is not much synovitis, then it is a case of arthrofibrosis. And even if we manage to maintain the sphericity of the femoral head, the patient is not going to benefit from this treatment. Now, I will just show you a few MRIs which will help you identify when we are not supposed to do this. As you can see, there is a very thin line under the subchondral area. This is typically found when there is a fluid into the subchondral area. And this is a picture of a patient that I did a total hip replacement. And as you can see that there is a severe delamination of the cartilage, and this would not work in this patient. Again, there is too much of a disease where here the whole femoral head is involved. There is more than 90% involvement of the femoral head. There is nothing remaining, or there is no chance or vascularity of the femoral head. In such cases, I think again, total hip replacement is the better alternative. This is the patient with again nearly complete femoral head involvement, where I have done a dual mobility hip. The patient was around 45-46 years of age, and this is the picture of the patient. Again, the lesions which are very close to the articular cartilage. Now, I feel that subchondral bone is nearly like an end organ, because whatever changes have happened in the subchondral bone over a lifetime of the patient, 20 years, 30 years, they are difficult to replicate again. So we should not be curating out in the subchondral zone. If we curate out in the subchondral zone, we are basically priming the patient for an early collapse. So whenever there is such a lesion, where the lesion is less than 1 centimeter from the subchondral zone, as you can see on the X-ray also, and on the MRI also, I feel that these patients will should be observed, and we should not accelerate the collapse of the head by drilling into the subchondral region, where we will, I feel that we will precipitate early collapse. This is what Dr. Rajkumar was talking about, that this is a patient which I have followed now for almost 3 years, and she keeps on coming to me every year with a fresh MRI. And here you can see that it's absolutely a medial lesion, though it is a significantly large medial lesion. And I think on the MRI, the lesion is more than 30%. You can see that over the 3 years, the patient has not developed fresh symptoms, but it is just that she is afraid that one day it will collapse and it will involve the lateral pillar, and that's the reason why she keeps on getting these MRIs. But I don't think this will progress further. Relative contraindications of this procedure are patients who are on low dose steroids. For example, glomerulonephritis patients, they have to take 2.5 milligrams of isolone. And I have operated on few patients of glomerulonephritis. The patients did absolutely like any other patient. Now, in case the patient has got ankylosing spondylitis, if it is involving or any other inflammatory joint disease, we make sense that we offer them a hip replacement. Now, patients with significant FAI, like this patient, this was a young lady, and as you can see, the FAI here is very significant. Though she has got AVN, the FAI is the one where there is hardly any cartilage remaining here. So even if the sphericity of the head is maintained, unless we are able to do something for the FAI, the patient will not really benefit. Now, I have had one more patient who's nearly completed 2 years of AVN therapy. He gets pain on abduction and cross-legged sitting, which is a classical feature of a FAI. And whenever I internal rotate his hip, he gets a severe catch into his groin. I am planning to do an arthroscopic excision of the cam lesion. And I don't know how the result will be, but I think we will be planning it in the future. His head is spherical and maintained. So it will be a very interesting thing to see if he gets a relief of symptoms from the FAI. This is a post-sickling AVN, and because of the nature of the disease, as you can see, that this is more than 2 years follow-up actually, and the head sphericity is maintained, but there is the problem here is that there is arthropfibrosis. So though she's able to do all her normal activities, walking is painless, but her range of motion of the hip is severely restricted. And she's, I think, around 24, 25. And I've already told her that the only way to get range of motion is probably by doing a total hip replacement. But she is saying that right now she's happy with whatever hip she has, and we are just observing her. So this was my short presentation about when not to do ALCO. And if Dr. Rajkumar permits, we can take some questions on that.
Sure, sir. Thank you for your very lucid presentation, Dr. Gauresh, as usual. And now the paper is open for discussion, and I'll invite questions from the other panelists on this forum.
May I ask a question?
Sure, sure.
Gauresh sir, the lady you talked about who had medial lesion, only medial lesion for the past 2 years, does she have any symptoms? There's any restriction of movements? And if so, how to manage that and how to treat those symptoms? I mean, painkillers or?
Yeah, so see, she gets occasional pain in the hip, and that is managed by NSAIDs. And these are basically small episodes where she gets occasional pain in the hip, and again it settles down. So I would label it like, like osteoarthritis flare-up or something like that, where the patient has to take some NSAIDs for a few days. But the range of motion of the hip is absolutely normal. She doesn't have any restriction of any of her activities of daily living, and she's able to do almost everything. So this is actually, that's the reason why there is no need to do anything.
Okay.
Yeah, I think That was a wonderful presentation, Gaurish. I think
Thank you, sir.
I think I've heard a couple of times your talk. Every time I learn new things from you.
Thank you, sir.
I just wanted to know, do you ever do pure core decompression or symptomatic relief?
Sir, I have worked with David Hungerford, who was the person who introduced core decompression in English literature. Now, when I worked with him in 2007, for all hips which were more than 30% involved, he was doing total hip replacement. I spoke to him about doing core decompression, and he was absolutely convinced that core decompression does not work in those patients who are in need of it. It is an excellent treatment for those patients who do not need it. So for those lesions which are medial or they are at very low chance of collapse, it would be a cure for them. But for those people who have large lesions, subchondral lesions, typically because there is no biological augmentation involved, core decompression does not work. Now, again, I would say that why does ALCO work? You know, that is one thing that we are all tried to find out. And the way I think that the reason why it works, I think, is that these osteoblastic cells, and I have got a couple of images which I will show you later, where the osteoblastic cells are capable of forming new bone very rapidly. So when we are curating out the bone from the femoral head and we are replacing it with osteoblastic cells, the new bone formation is very rapid, and that supports the subchondral bone and prevents it from collapse. We cannot really remove all the
I think you lost the connection again. I think he's absolutely right in saying that core decompression alone probably will not help in these patients. And as I said in my talk, initially we extended OSCRO for people beyond the stages, and those are the patients coming back now for symptomatic, and probably some of them have done total hip replacement. So I think it's a good lesson from those patients who did not get benefited from OSCRO. So it is important that we select our patients and select the lesion, especially. I think my talk was again when not to do, when to do, and when to wait. So I think it's important because otherwise you get bad results if you aggressive and do not understand the disease.
I agree with you, Dr. Reddy, and Gaurav, as usual, will give us new insights on every presentation that he makes. And it's important for all the viewers who have witnessed a presentation by Dr. Gaurav, that we need to be very methodical and very choosy in how we do our procedure, especially if you want to do anything biological. Because to convince a patient for a biological procedure itself is a big, humongous task. And then we say when we preserve the joint, we need to be very choosy and correct in our decision making. And that comes from experience and learning over a period of time. And I think with Gaurav now back, and if we can ask you some questions, we had lost you for a couple of minutes. Is that okay, Doctor?
You're muted, Gaurav. I think you can unmute yourself.
Thank you.
I was in your absence. I was saying because I think I've seen quite a few cases where people just did a core decompression, they progressed rapidly and needed replacement. So they have to understand the pathology, how it behaves. So it's important that they identify the right indication. And some of my patients, initially I was, I think, with extended my indication to a little collapse or maybe more than 50% of the head involvement. And they came back, and a few of them I did a total hip replacement.
I feel personally, sir, that the fault lies in the thinking that core decompression gets new vascularity in the femoral head. Now, all of us have done the procedure, and when we curate, all of us can see that there is, because of the bleeding, that there is no lack of vascularity in that area. So the blood is already there. The problem is that a lot of people, they will drill the subchondral bone to get the vascularity into the subchondral bone and end up damaging the subchondral bone. So that is what I think causes rapid collapse of the femoral head. So if at all core decompression is what somebody likes, then I think they should stay away from the subchondral bone, which, like I said, it is like an end organ almost, and it is difficult to replicate it because it is in that position after a lifetime of bearing stresses of the body. So it cannot be replaced, and even if even if new bone is formed there, it will never be strong enough to take the body's weight.
Question is open now for all the panelists. We know that idiopathic cause for AVN is maximum, whereas the rest of other causes will fall in the minimal category. Out of that, if we have to pick in causes like SLE, thalassemia, sickle cell anemia, as Dr. Gauresh was mentioning, how confidently we can, tell them that yes, Osgro will give you a relief, or will give you some improvement in the stage of AVN that you are, or should we hold back such a treatment for these kind of disease process?
Can I answer?
Yes, sir, please.
Yes.
Yeah. So again, the whole problem is I had a patient of sickle cell anemia, and the sickle cell anemia patient went ahead and got a transplant. Now he is nearly 4 years post Osgro. He's doing fantastically well. Not only he got Osgro for his shoulders, both shoulders, but both hips as well. However, bone marrow transplant per se cost, at least in Bombay, it costs 17 lakh rupees. So it's a very expensive treatment. It is not everybody can get a bone marrow transplant, and obviously it's a very procedure of very high morbidity where they talk about mortality. They cost about around 10% mortality of the patient in bone marrow transplant. Morbidity is a completely different So in sickle cell we can pick and choose, but the problem with sickle cell is always that the hip becomes so painful after a sickling AVN that the patient finds it very difficult to mobilize the hip, and that leads to arthropibrosis. It not only leads to arthropibrosis in the hips, but in the shoulders, in the knee, wherever there is AVN, there is a significant arthropibrosis which is present, which is extra-articular as well as intra-articular. So that is the main problem with this thing. Second is, like I said, if the patient is on a low-dose steroid, I have not seen that it has really impacted this treatment. So low-dose steroid appears to be a relatively safe way of, of doing these surgeries. However, if the patient is on high-dose steroids, and if the patient is on cytotoxic drugs, then I think again I feel that I'll be very reluctant to do this.
I think I will agree with Gauresh. I think it's very. I think he said everything very clear, and that's what I do. I fully agree with him whatever he said.
Because I see in clinical practice these kind of patients who come with SLE, and they are not a happy lot of patients when you try to do Osgro for them.
Yeah.
And whenever they come for follow-up, we are of the opinion, we feel that so it is like that. They are not a happy lot at all. So should we really offer SLE patients Osgro, or not is now thought process that is going on, wherein we have to just wait and do some other.
Yeah, sir, Sir, I feel that what you said is a very, very correct clinical picture. Then there is a lot of studies also on this, that SLE as well as rheumatoid arthritis. Not only does it affects the patient's body, but there is patients are depressed. And offering such a long-term therapy where the results are, they take some time to come, will be, I think, difficult. Advantage of offering total hip replacement in these patients are that they are not very highly mobile patients, nor are they likely to be doing a very high impact activities where, even see RA in a severely or even JRA patients where the joint is destroyed at the age of 22. Routinely, total hip replacement is done. And such total hip replacement, they last for a long time. The reason why they last for a long time is simple, because these patients, they just want to go around the house in a pain-free manner. They will do some shopping, and their activities of daily living is completely different. While an active person, let's say even up to 40 years of age, suffering from AVN, he is normal in mind and body in all other respects. So that is the reason I feel that there is a big difference about SLE and rheumatoid arthritis, where I think this may not be the correct procedure, like you very rightly pointed out, sir.
Because I happen to manage a lady with bilateral AVN with SLE, who is an engineer by profession. And she was not a happy lot at all over 2 years of follow-up. Then finally we had to offer her a total hip for the right side, which was looking congruent mostly on the X-ray, but she kept on complaining of pain on the right hip. Now what we have done is we have done total hip, and we have sent the head for biopsy. We are waiting for the pathologist to tell us whether what we have done is a benign procedure, or it did really help her, or a patient conned us by telling the pain was there on the hip more. But when you looked at the head on table, it was very spherical, not much of soft spot that we see on the head, wherein you can see that it is collapsed. So probably in the next couple of meetings, when we have the results with us, I'll be able to share with you what happened to that biopsy.
Yeah, can I just add?
That will be very instructive, sir.
Yeah, I think as you rightly said, Gaurav, these patients are low demand. They will be very happy with replacement rather than anything else. And basic problem here is inflammatory, synovial inflammation, which is the main part for the pain, main component of the pain. The head avascular necrosis secondary to synovitis or whatever, because of the joint pathology. So if we do not deal with the joint itself, which is inflammatory process, I don't think they will be happy. And for them, in my opinion, the best option would be a replacement rather than anything else. Because main problem is in the synovium and in the joint itself.
Rajesh, your thoughts on the discussion? Yes, please.
Yeah, SLE and such patients or rheumatoid patients who are on steroids and other cytotoxic drugs, of course, as Gaurav sir rightly mentioned, there is no point, who are on heavy doses, there is no point in offering them Osgro. I just wanted to share a case since we are talking about THR. So we had this young lad in his 30s who had stage 2A, Pickett stage 2A on MRI. We offered him Osgro, but he somehow went ahead for extracorporeal shockwave therapy. And I don't know whether it works or not. For the first 20 days, he had very good pain relief. After 20 days, he had such a pain, he straight away went ahead with THR. So what could have caused that? Synovia, synovitis?
Very difficult to say. I don't know.
Yeah.
So, but I think people do come. I think in Hyderabad, there's so many machines, big machines. They put through the machines and they say they're treating whatever, shocks and all those things to generate stem cells. But I think If patients get better, if they get better anyway, if they get worse anyway without this treatment. That's what I believe.
It's basically lithotripsy. It was basically the same procedure. Extracorporeal shock wave therapy is lithotripsy that they do for renal stones.
Correct.
I don't know how it works or how it progresses, how the disease progressed, or maybe in just 20 days he had such pain. He went ahead to some other doctor and straight away went gone for THR. I don't know.
Damage the head. We don't know.
Yeah, sir, Gaurish sir, any idea?
No, I have done lithotripsy on myself. I know how it feels, but I don't know about the femoral head. I can't think of the reason.
So now I was told that Ashish is going to be.
Sir, just 1 minute. Sir Charul here. There were a lot of questions on the chat box.
Chat box.
Yeah.
Okay. Surgeon has asked some questions.
Okay. Ashok Sajnani. Okay. To all the panelists, do you give alendronate with your biological treatment? Reddy sir, Gaurish sir, anybody?
I do give, yes, for about 18 months.
My is that what I do is that in high risk patients, I'm giving teriparatide because that's a proven anabolic thing for osteoblastic cells. And in these high risk patients, I've had a very good result with teriparatide. I'm right now compiling the data of these patients. So I think by the next meeting, I'll be able to share that.
Thank you, sir. Second question is, do COVID AVN respond in the same way as other etiology of AVN?
I think we discussed about it. If COVID, post-COVID, the head involvement is significant, doesn't respond. And most of the time we see post-COVID, it may be combination of COVID as well as steroids. The area of involvement is more than usual compared to idiopathic or isolated steroid. So on the whole, the prognosis may not be as good. But if COVID with the limited lesions, I think they respond the same way like any other etiology.
Gaurish sir, your thoughts? Rajesh, your thoughts?
I'm personally, I don't know whether COVID is responsible for AVN or the steroid is responsible for AVN, because whatever COVID patients I've seen, post-COVID patients I've seen have invariably taken steroids. There is only one patient who has, out of so many, that he was categorically said that he's not taken steroids. But I feel that steroid and COVID combination is definitely increase the chances of AVN. That much I'm sure. And I think there is no response. So obviously post-COVID patients do not have that long a follow-up, because all these patients started coming in after around 6 to 8 months of the first wave. So right now my oldest patient is around just completing 1.5 years or so, but the response is the same. So I don't think that I feel it will behave like any steroid AVN.
I also think that COVID, non-COVID doesn't matter as far as the area of involvement is less than 50% and it fits the selection criteria of biological treatment.
Okay. Correct. Dr. Swapnil Kalanje wants to know what is the lifespan of an osteoblast cell. Anybody on?
Arul, you want to answer?
No, we want to know what outcome, yeah.
No, lifespan of osteoblast cell. That's all. That's all the question is.
They are your natural cells. So if you are replacing your natural cells, it is that whatever cells are there, osteoblastic cells are there in your body, it has got the same lifespan. As far as transportation and cell viability is concerned, I think I have been assured that it is more than 90% by the time that it reaches our hand.
Okay.
And Dr. Rajkumar, I think I would request you that please also give your opinion also to these questions. I think that will be also instructive for all of us.
Yeah. Ravi Batula, he has spoken about two things here. One is, sir, cytokine injection given by one doctor from Bangalore, and it is giving good results for AVN and MRI changes also are there. So he wants to know, does it work or does it not work? Number one. Number two, he says, Stemupeutics company is launching in ischemia of limb medicine, stem cell therapy. This injection can be used for AVN patient since it is a similar pathology. What do you think about L-arginine? So from my end, if I had to say, I don't have any experience of prescribing any injection called as a cytokine injection or any stem cell therapy that we use for limb ischemia in AVN. About L-arginine, I don't have any experience either. So my inputs on this would be limited, Mr. Ravi. Anybody else on the panel has this opinion? Kindly go ahead and please discuss.
I don't have any experience.
Sir, I will talk. Stem.
Yeah.
Sir, go ahead.
Yeah. So I think Charu will talk about Stemupeutics, but what I feel is that the basic pathology of AVN is misunderstood. I don't think that it is a ischemic pathology. So the whole point of ischemic pathology and trying to restore the blood supply of the ischemic femoral head is not correct. So it is like if you find a dead person on the road, you are assuming that he died by a heart attack. Only thing we can see is the body of the person. So all the cells are dead. So when the femoral head is dead, we are assuming that obviously the dead part will not have any blood, and therefore we are assuming the ischemic pathology of the AVN. Now, as all of us, if you examine the clinical picture of AVN, and if anybody has experienced ischemia in the body, that is an event. If heart develops ischemia, it's an event. Brain develops ischemia, it's an event. Finger develops ischemia, it is an event. The body will allow you to know that it is ischemia. All of us know that AVN is a silent disease. So if there was an ischemic episode which caused AVN, we would definitely know when this ischemic episode happened. There will be severe pain because of bone ischemia, like it is there in sickle cell disease, or it is there in Kaison's disease, where bone ischemia leads to severe, debilitating pain. But the classical AVN of what is steroid or what is alcohol, I don't think it's a ischemic pathology. So there is no point in treating lesion thinking it's a ischemic pathology. Now about L-arginine, if I will just go and then Charul can talk about the company. L-arginine is, I am using it, and L-arginine basically is a nitrous oxide generator. So what it does is that it causes dilatation of microvascular circulation, and I use it basically in the hope that it increases the blood flow and oxygenation to the osteoblastic cells. So that is the reason why I'm using it, not because it will cause revascularization of the dead femoral bone. Dr. Charul.
Yes. As per my knowledge, I know this Stemupeutics has developed the stem cell injection for a Burgers disease and Raynaud's disease. So it's not going to be for AVN. So they're going to use, as per my knowledge, for Burgers disease and arterial and venous disease. That's it.
Yeah. Thank you. And can we go on for the next talk of how to use Osgrow? Demonstration by Dr. Ashish. Charul?
Yeah, Dr. Neeraj sir.
Yes, sir.
So just
yeah, give me 1 second.
Yeah.
Hello everyone, I am Dr. Ashish Sharbat from Jahangir Hospital, Pune. I am privileged to be a part of this master course on Osteoblast implantation for AVN. I am extremely privileged to be talking on Ortho TV, a great initiative. I thank Regrow Life Sciences, my seniors, Dr. Rajkumar Amravati, Dr. Gaurish Palekar, Dr. Reddy, and Dr. Rajesh. We have successfully treated more than 200 patients with Osgrow, and day by day our confidence and our approach towards the patient is gaining a lot of confidence. We will be showing the way we do implantation of the cultured osteoblast in the following video.
Hello friends, so today we are going to talk about avascular necrosis of the femoral head, what to look clinically. So seeing the x-rays here, now you can see this lesion, these are the compression lines, and here is the lesion on the weight bearing area. Now the most important diagnosis here is done in the T2 weighted image, where you can see this double line sign, which is only seen in AVN hips. So this is the double line sign. If there is no double line, it can be any other diagnosis, like it can be just an edema, it can be just some osseous bone formation there. T2 is more important. In the T1 images, since there is no extra water, you cannot differentiate between AVN or any other diagnosis. So T2 weighted images are the most important for diagnosis, and check for the double line sign. The Osgrow trolley setup. These are the regrowed Osgrow cells having osteoblast, chondrocytes, chondroblasts. These are the mixing units with thrombin and cells, and these are the sterile syringes, and this is for combining, making the cells into a gel form. So this is the typical setup for doing a core decompression with a modified CT based C-arm. This is how we start. A percutaneous wire, which is seen in the CT based image intensifier. We go in the lesion. These are the typical instruments that are used. This is used for the core decompression, and these instruments for removing the lesion. All super sterile and high tech. This is the flower tip reamer. Now the flower tip reamer has reached the lesion, and see how systematically the lesion is being tackled. We will also tackle the superior area from the same hole, and then we will put the cells of Osgrow along with the gel. Mind you that you have to remain subchondral, you cannot go above the head, and systematically you should decompress the bad bone. Now this is how we start scooping the lesion, taking out the bad bone from all the directions, and there are different angle scoops, around 8 scoops of different angles, so we can tackle all the bad bone. Now see how we are tackling the superior area. Reaching with various angles is very, very important. Many a times it is seen that you just go in the center area and come out. That is not important. Such a small incision is used. hardly any bleeding, and this is the typical cored out bone. Then we'll give a nice wash and lavage. We suck out the bad bone, give a copious lavage so that it is totally decompressed, and a good bleeding is a sign of very good decompression. This is how the remaining bony pieces are flushed out, and see the healthy bleeding. This is a very good sign that you have decompressed it very well. Once the venous decompression is done, arteries are going to follow, and within a fortnight, new blood supply and everything is going to start. So very good decompression, and in a very, very small 2 centimeter incision, all percutaneous. Now this is time to insert the cells. This is the lesion is, you can see it's completely scooped out. A nice rim of cortical bone is seen, and the lesion becomes a big hollow. And here are the cells to be inserted, and that's how we do it. We'll just push it in slowly under CT guided C-arm imaging, and thrombin with gel is put inside. You have to wait for around 8 minutes for the cells to settle, and just close it with a single stitch.
Thank you everyone. I hope you like the systematic approach that we take. Most of our cases are in epidural. Weight bearing, partial, offloaded, day 1, 24 hours discharge. I again thank Ortho TV, Regrow Life Sciences and my seniors. Thank you.
Take this opportunity to thank Ashish for this wonderful demonstration. On behalf of Regrow and Osgrow, I would like to thank Ashish once again. Any useful tips from Dr. Gauresh or Dr. KJ Reddy sir or Dr. Rajesh would be useful to practice this clinically. Dr. Gauresh sir.
I don't use the percutaneous technique. Second thing, I feel that it is important to prevent the backflow of the cells. So I block because this whatever volume that we have, I think it's very important. A lot of times there is a backflow. I don't know how Ashish is managing to prevent. Second thing is that again, washing out with saline is not something that I do. I don't know about it, but I feel that the blood which is remaining inside, it's a good medium for the cells. So I don't think that is something that I do. Other than that, I think it's a new way that Ashish is doing it, and should he's an arthroscopic surgeon, so he thinks in a way of doing it and decrease the immediate pain, post-operative pain to the patient. And very interesting to see his long-term results.
Dr. Rajesh, your thoughts on that? Dr. Reddy?
Sir, I also open it up quite a bit. I see the lateral cortex well, and I put one spike in front and one spike behind, and then take proper entry. And I do wash it once or twice with a 10 cc syringe also, because the debris of the bone that we take out with the scoop, just to remove those debris, that's it. Not extensive lavage or wash. And at the end, generally put bone plug to seal off the hole in the cortex. Otherwise, I do it in the supine position on the fracture table, just like we do a core decompression or DHS in standard way. And while injecting the cells, we generally tilt the table to the opposite side, 15-20 degrees as far as we can. That's it.
Dr. Reddy sir, your practice?
Yeah, I think yes, I do open, I mean, it doesn't take big incision, small incision only. Use bone spikes, see the lateral cortex. I think Gaurish rightly said it's important that we should see the backflow because the volume is about 4 ml. 4 ml we're injecting. It's a big cavity also, may not be right thing to do. I wash out, I pack with the distal part with adrenaline pack and remove it. And I block the hole with a screw so that I'm more concerned about backflow. I mean, so we inject and everything comes out. That's more important. And tilt the table, as Rajesh said. We inject in the areas where curated the bone and made the hole.
This is a hypothetical question for all the panelists. So imagine you are doing the step 1, wherein you are passing your guide pin, and inadvertently the guide pin violates the cortex, subchondral bone. Okay. And in your clinical practice, you go ahead and then do all the procedure that you're doing, Osgrow and everything. And do these patients perform differently than the patients where the subchondral bone is not violated by the guide pin?
Guide pin is very small, of very small diameter. If by inadvertently guide pin does pass your subchondral bone, you just pull it out a bit and take care that the reamer doesn't go to that area. The reamer doesn't penetrate the subchondral bone. Rest assured, the injection is in gel form. It is along with fibrin. So as long as your spinal needle doesn't penetrate right through the subchondral bone into the acetabulum, so you can be assured that the cells will remain in the part that you want them to be.
Yeah, I think sometimes what happens, we don't put, I don't put personally, my assistants, one of them will be using, starting off the case. So it did happen to me. And what I did was, I redirected, I changed the guide pin position to a little different position. And of course, did the reaming and everything, and try to, whatever little bone impaction, try to impact that area, because I don't know, to be honest, even if it is minor hole, if it leaks into the joint, probably it may not be a nice thing. So changing the guide pin direction, try to probably impact some bone into that path, might help.
Gaurav sir.
I have like Dr. Reddy said, that this is not hypothetical for me. And in one case, what happened was that there was a bone in the reamer, and because of the bone in the reamer, the guide wire jammed into the reamer, and when I was drilling, it penetrated into the joint. Now, every time I'm doing the reaming, proximal reaming, I'm collecting bone from the outer cortex. And like I mentioned in Goa, what I do is that I will, if you collect all that bone, which is not avascular bone, but in the first around 4 to 5 centimeter bone of the proximal femur, and you take it separately, you cut a 2 cc syringe and you cut off the head, you put everything into the 2 cc syringe, and then you push the plunger, you get a nice bone plug. It exactly fits into the 8 mm drill hole. Normally, I use this in the outermost cortex to allow faster healing of the outermost cortex and prevent backflow also. But in this case, what I did was I pushed it all the way inside, because I was worried that the cells will not get really, because what happens when we are injecting these cells, it is like we are pressurizing the cells. So these cells are going not only in the cavity, but probably into the other parts of the bone also, and spreading there. If there is a leakage because of the guide pin hole, then that kind of tamponade effect will also not be there. So that's the reason why I packed it all the way up to the subchondral ear with a blunt ear, and then there was no difference in the result actually of the patient.
So why I asked this question was, as Dr. Reddy rightly put it, it is usually our juniors or our assistants who start the case to pass the guide pin just to have a hang of how to do a procedure. But having rightly said from two experts saying that yes, you go in and pack the area where you cause the rent, because we want all that you're injecting to be inside the joint, inside the head of the femur, not some percolating into the joint. So we need to be very having a series where all the patients where the head was violated by the guide pin, how they are performed. So that would be a nice thing to know if they are performed differently, or if it is okay to percolate the head. That was the thing here. And now for the final talk of the session, if I can invite Dr. Palekar to give us out of his vast experience, how the outcome of each patient, or how the longest outcome was, and how they performed differently after OSGRO. The long-term studies by Dr. Palekar, please.
Actually, I will just go through this very fast. Unfortunately, I have 2 days post-op patients to visit, so if I will be very brief with this, if you allow me, sir.
No problems.
So I think we've already said this, that uh, disease burden is basically, I feel that it is a known thing that more than 70% of these patients would require a THR within 2 to 3 years of diagnosis. And if we have increased the lifespan of this, I think we made a significant contribution to preventing a total hip replacement. One thing that all of us, when we are dealing with AVN, we should look for is that this is a very classical case, very early AVN 2A, left side 2B. But whenever you are looking at this, we should see what stage it is and what grade it is. So staging is Fickett and Arlett, and grading is obviously by the ARCO classification. So we need to know how high grade, what are the chances of collapse of this head. This has already been discussed, and this is the slide that I wanted to show you, that the spillover cells are forming bone in a outside the canal. So this is very instructive for me, that that the capability of forming bone into even muscle, these osteoblasts are very biologically active. Now, this is the 8-year result of a patient that I had done very initially at the stage. The patient is absolutely normal. You can see the x-rays, these are nearly 8 years old x-ray. Though you can see evidence that there will still be evidence of lysis or whatever, but the patient has not collapsed. She has got full range of motion, and basically all her problems with respect to AVNs are over. So this is a bilateral AVN. Thankfully, we were able to get into her when this was at a stage 2A or stage 2, now ARCO, where there was no collapse, and the AVN was more than 50%. This is a case that I have put here to show how AVN behaves, because this is one of my longest follow-up. The surgery was done nearly 11 years ago. She's a 27-year-old female, took COX, steroid for COX, and it was a bilateral grade 2B AVN. So bilateral collapse was there, and these were her hips. Now, as you can see, initially the X-ray doesn't look so good. This is at 22 months post-op, and now I have got a series of x-rays to show you and how the remodeling of the femoral head has happened. This is at 24 months. You can see that there is a bone formation into the area or the cavity that we have curated out, and this is at nearly 5 years post-op. The head is still congruous, the joint space is maintained, and the last time she visited me, this was her result at 10 years. Absolutely normal range of motion. This time she was married and did not want an x-ray, but on examination, I could not make out that she's ever had AVN. It will be very nice to get her X-ray done whenever she comes next time. But what has happened over a period of time is that the femoral head has remodeled, something like what happens in Perthes. And it is right now, it is a fairly congruous hip. So her range of motion is good. And definitely she is not very keen on getting a hip replacement done because all her needs are served by this hip. So we have definitely managed to avoid a hip replacement and give a normal function at 10 years. This lady recently visited me again. This was her 8 years and next time I will put her results at again at 10 years. Absolutely normal function. She had pain in her ankle. That's why she visited me and I took the opportunity of x-raying her hips. Her hips are absolutely spherical and concentric. This is again a 10-year post-operative result. This guy, if I remember, was on low-dose steroids. And at 10 years, you can see that the relative sphericity of the head and the joint space is maintained. Though you may see some evidence of AVN into the femoral head, which is almost like a scar. It is same, I feel like it's like a scar on the skin. So therefore, there is a scar on the femoral head. But I don't think that this patient will deteriorate further. He's able to do almost all activities that is required. This guy is a bodybuilder and he routinely lifts and does squats of more than 150 kgs. That's what he tells me. He's 4 years post-operatively, both hips operated. The right hip was at a stage 2A region or stage 2 where it is concentric, round, absolutely okay. And the left hip is was 2B, where again as you can see, there is some evidence of slight lateral osteophyte where there was initial collapse, but at 4 years the patient is doing very well. Finally, this guy is one of the most recent follow-ups. Again, left and right hips more than 50% involvement, absolutely normal range of motion. His right side has got some symptoms, and as you can see, there is a significant cam lesion there, and this is FAI, which I confirmed was there even before the preoperative picture. So this is, nobody can say that this is an osteophyte which is developed because of arthritis, and the patient is asymptomatic except for extreme abduction is painful for him. So these are all the cases that I have tried to show you. And the take home message is that in these young people, I think hip preservation is a necessity and everybody deserves a chance, especially if he's young and if he's in that stage of the hip where bone preservation is possible. And autologous cultural osteoblast, though it may be a new technique for a few of you, there are fairly long-term results available now of more than a decade, which shows that this thing is there for stay right now. Thank you, everyone.
Thank you, Dr. Gaurash, for your results. And it is really encouraging for all those who want to practice, autologous cultured osteoblast for managing AVN in clearly indicated cases. I really congratulate you for your research and your wonderful follow-up of these patients. Because if we don't have follow-up of our patients, we are left with, we fall short of, trying to do the next best thing for such a patient. So I really appreciate that you have got long-term follow-up of such patients who may have done autologous cultured osteoblast. And on behalf of Regrow and Osgrow, I congratulate you once again for your wonderful work, and we wish you happy holidays too. But before you go, if there are any questions from other panelists for Dr. Palekar sir. Any questions?
Wonderful work.
Yes.
Gaurash, I think that's wonderful. I think it's important to have good follow-up of the patient. Then only we know what we're doing and we can give a clear message to our colleagues and upcoming surgeons. wonderful work you're doing.
Thank you, sir.
Have a great holiday.
Dr. Rajesh,
Thank you
your
so much,
thoughts?
sir.
Amazing follow-up, sir. Congrats.
Okay, here I would like to just mention anecdotally, all of us know that there is a race called as a tortoise and a hare. The end of the message by any teachers whom have told us was, slow and steady wins the race. Everybody has heard this, I'm sure. But in addition to being slow and steady, I think the tortoise was more patient also. Like Dr. Palekar, to wait for 10 years to get these wonderful results. I congratulate you once again and have a happy holiday. Over to you, Dr. Charul, to add a few notes from your end.
No, I just want to say thank you to
Dr. Rajkumar, if it is possible, I would just like to leave the meeting. I've got an early morning flight and you have patients today.
Thank you, sir. Thank you for sharing your thoughts, and we will allow you to leave the meeting, sir, and have a great holiday with your family. Thank you so much.
Thank you, sir. Thank you, Dr. Rajesh, and thank you, Dr. Reddy. Thank
All
you.
the best. Take care.
Yes, Charul. Closing remarks by you and Dr. Neeraj.
I am thankful to all the panelists and especially Dr. KJ Reddy sir, Dr. Gaurish Palekar sir, Dr. Rajkumar sir, and Dr. Rajesh sir and Dr. Ashish sir. And thank you to Ortho TV, Dr. Neeraj sir. So thank you for a wonderful session, which was very informative, sir. So over to you, Dr. Rajkumar sir.
Thank you once again for all the panelists, Dr. Reddy sir and Dr. Rajesh. And thank you for the opportunity given by the Ortho TV as well as the Regro Sciences for bringing out this experience of managing in AVN, which is a difficult problem to treat biologically. And I'm sure there will be keen audience who have listened to the master talks. We'll try to hone their skills and practice this effectively in their day-to-day practice. Thank you so much and have a good night. God bless you all.
Thank you
so much.
Bye-bye.
Good night, sir.
Bye-bye.
Good night.
Thank you, sir. Good night, sir.
Bye.
Thank you, sir.